Hi, my name is Rich Rosenfeld, and on behalf of Consumers United for Evidence-Based Healthcare, I'm delighted to share with you some information on consumer involvement in guideline development, particularly why and how you as a consumer can participate on guideline panels. I'd like to acknowledge the American Academy of Otolaryngology Head and Neck Surgery, where I'm strongly involved in their guideline development efforts. They've been very accommodating over the years in honing our guideline processes and particularly receptive towards consumer involvement in our guideline panels in the past years. I'm also speaking as the chair and founder of GIN North America, the Guideline International Network, North American Network, which is also very interested in consumer participation and input. Now, the first question you as a consumer should ask is, why bother with guideline development? Don't we have enough rules and regulations? Why do we need more? And fundamentally, the answer is simple. Healthcare costs continue to skyrocket, and there's tremendous variation in the way healthcare is delivered, not just across the U.S., but regionally, nationally, internationally. And clearly, we want to avoid overuse and also underuse of resources. So for that reason, we do rely on guidelines. The Institute of Medicine did approach this topic a few years back in recommending several challenges to current health policy delivery. The first has to do with the unsustainable rates and the cost of healthcare, as I mentioned, as well as the geographic variations. Those were highlighted in the previous slide. The other issue has to do with the quality. And it's clear that the quality is quite variable in the way healthcare is delivered and could probably be improved. Consumer involvement has been sporadic at best in healthcare delivery, development of guidelines, policies, performance measures, and also just the ability to make informed decisions about what's medically necessary is really a critical part of third-party decisions and coverage decisions. So for all these reasons, we do need evidence-based guidelines to help fill in the gaps and provide the best advice for physicians and clinicians in general how to make healthcare decisions. The Institute of Medicine has also in the past year, in the spring of 2011, released standards for developing trustworthy clinical practice guidelines. And the first question, of course, should be, what is a guideline? I give you here their updated definition, which includes several key words. Guidelines are statements. They're not a review article, they're statements. They give very actionable, clear statements on how someone should act, what should be done in a certain circumstance. They're really intended to optimize patient care based on systematic review of evidence. This is not anecdote at work, it's systematic review. I know many of you, as part of CUE, are involved in the Cochrane collaboration, and Cochrane reviews are often the heart and soul of many guidelines that are developed. There's also an explicit discussion of benefits and harms in developing guidelines, which isn't always the case in other types of documents or health policy. The end of a guideline should really be a series of actionable statements, things that could be implemented, done, and performed clearly and unambiguously to achieve a certain outcome. To get to that point, we start by saying, how can we improve quality? What are the areas related to this disease, this entity, this process, this symptom that could be improved? And we consider those in light of the best available evidence, and then of course the evidence gaps. Many times there's quite a lot of missing evidence or suboptimal evidence, but we still need to act. We can't just limit guidelines to situations where there's robust evidence, because sometimes some of the most common conditions that we need guidance on, unfortunately, have few randomized controlled trials or systematic reviews behind them. And most importantly, we need a guideline develop group, a panel. And part of the purpose of this presentation is to discuss how you, as a consumer, can be a part of this panel and really understand the process and interact effectively. Once all this is put together, there's still a process of clinical consensus where expert opinion is put in there to blend all this into a final product. At the American Academy of Otolaryngology Head and Neck Surgery, Our guideline development takes place in the Research and Quality Unit. We believe that guidelines are indeed a form of research and need to be conducted with the same rigor that goes into research investigations. And for that reason, the people who staff and run our guidelines are the research and quality staff, often the senior staff. Our processes have been in place since 2006, and in that time, we've published 5 multidisciplinary evidence-based clinical practice guidelines. We have 2 more that are in process now and another one that's in press. So we've been fairly efficient at producing these. Many groups, the guideline process can span 2, 3, 4, even more years. We ideally like to complete this in 12 to 18 months. People care about guidelines. These are some data from the National Guideline Clearinghouse just showing how often people are viewing some of the guidelines we've published in the past few years. At the top is a guideline about swimmer's ear, over 50,000 views, an incredible interest in that. And then it trickles down from sinusitis to our most recent guideline on tonsillectomy in children, which is probably going to be our most highly cited, but at the time of this only had 1,300, 1,400 hits because it had just been released by NGC 2 or 3 months before the data were culled. Getting back to our standards, one of the first standards that the Institute of Medicine put forth is regarding the composition of the guideline group. And this really has to be a multidisciplinary, a balanced group in terms of disciplines, in terms of experts versus clinicians, grassroots involvement. It has to be balanced. And the reason for this was articulated pretty well in the past by Shakel and also by a previous IOM report. If you have diversity on your guideline panel, you're more likely to get all the relevant evidence because different viewpoints are familiar with different sources of evidence. You're going to have a higher chance of really addressing meaningful practical problems. You'll build support because clearly if you want people to follow a guideline, all these stakeholders and people involved in the use, including the public and consumers, need to be involved in development. Importantly, you tend to balance the biases. Everyone brings some degree of personal, professional bias to the table, and by having a robust group, it'll help balance these out so no one point of view prevails. For example, we did a guideline, a very highly cited and well-received guideline on adult sinusitis a few years back, and here's an example of the panel. The names highlighted in yellow are the non-ENT docs, the non-otolaryngologists, just showing how on many of our panels, most of our panels in otolaryngology, the ear, nose, and throat docs are a minority. We want to balance this with input from all the relevant disciplines. Now, if you look carefully at this list, you might notice that a certain group is missing, and that happens to be the consumer group. I think this was our last guideline before we actually started including several consumers on all of our panels. And we like to begin with the end in mind. The end is to have an actionable, meaningful guideline that people will follow, that's implementable, that's going to have meaning to the stakeholders. And sometimes the missing piece of the puzzle is the consumer. Without the consumer point of view, it's really hard to say that the topics you're even considering and the way you're phrasing it and wording it in a guideline are going to have relevance to the people to whom the guideline is intended. So consumers are that missing piece of the puzzle in many guidelines. What happens if consumers are not involved? And we'll just take a little historical deviation here. These two folks, this is Sigmund Freud and his personal physician, Wilhelm Fleiss. I'm not sure how many guideline panels they sat on, but at the time they were practicing in the late 19th century, early 20th century. There was an interesting condition called the nasogenital reflex. This had actually been described by an otolaryngologist, John Mackenzie, who saw that histologically, if you examine in the laboratory the tissue on the bones in the nose, the turbinates of the nose, the things that swell up when you get a cold, as well as the tissue In the genital region, particularly the clitoris, it's the same tissue. So only 2 places in the body do we have this erectile tissue, and there was felt to be a link between the two, and this actually goes back to antiquity, of some nasogenital reflex. Sounds crazy, but Freud had many patients who suffered from painful menses, dysmenorrhea, and his physician, Wilhelm Fleiss, who was an ear, nose, and throat surgeon, decided that perhaps he could cure them of painful menses by treating the nose, since there's a link between the nose and the genitalia. And he actually anesthetized the nose and removed parts of the nasal bones, the turbinates, in many patients, allegedly improving their dysmenorrhea, their painful menses. This was taken to the next level a few years later when a laryngologist reported in the Journal of the American Medical Association that he had cured 93 women of painful menses simply by removing bones in their nose, of course crippling them nasally. This had many side effects. Even until the 1940s, this concept was appearing in review articles. So we can ask ourselves, how do some allegedly very smart, in some cases luminary people like Freud, make such silly decisions? If we had consumers involved in these decision-making processes, would the outcome have been the same? I suspect not. I suspect the voice of reason might have prevailed at some point, and clearly now we know this is unsupported ideas. There are certainly no randomized trials to show this, and no one talks about this anymore. I think William Osler said it best, that common sense in medical matters is rare, and it's usually an inverse ratio to the degree of education. Many doctors, especially those on guideline panels, have gone through many years of education, of residency, of fellowship, of additional education, and in some cases, unfortunately, all common sense has been drained out in the process. I'm not suggesting that consumers are uneducated, but that this balance brings back some of the common sense to the process. The standards from the Institute of Medicine go on further to say that patient and public involvement is key to this process. Patients should at least be involved in the scoping phase when the questions are formulated, and an advocate or a patient consumer organization representative should be on the guideline development group. And this is for the reasons we just discussed. It's to bring that common sense to the process. What are the possibilities for involving consumers? At the most basic level, the simplest thing would be to just communicate. In this case, a guideline is developed, it's shared with the public, with consumers, and maybe a little feedback occurred, but it's a very rudimentary form of interaction. A better form would be to get feedback from the public, from consumers in the development process, and this is where the IOM recommends engaging patients to help in the scope of a guideline, being sure that the right questions are being asked with the right outcome measures. Probably the best way is to really have an interaction, to have participation, full participation of the consumer on the guideline development group. This is the model that we follow at the American Academy of Otolaryngology, Head and Neck Surgery, and we think this is the best way to do it. The reason we do this is severalfold. Having consumers in the room brings a few things. I think consumers are often very passionate, in a good way. They wake up the room. When you start proposing things with harms or adverse effects and not really fully fleshing them out, this raises some hairs. They give perspective. They also are often skeptics, which is good. They're healthy believers in uncertainty and often bring that to the table. They have tremendous respect for harms and adverse events and often will advocate for patient education, shared decision making, when others in the room are quiet. So I think this perspective is critical in developing guidelines. Beginning again with our goal in mind, we do recognize that consumers are part of this puzzle. The question is, does the piece of the puzzle also have to be an expert? If we're doing a guideline on Tinnitus, ringing in the ears. Do we need to have consumers involved who either suffer from this or are very familiar with the condition? And the answer is absolutely no. We do have content experts on Guideline panels. They're often a minority. We really need that diversity of opinion. Content experts are often very divested and personally biased in their own research point of view, so there are some downsides. We need informed consumers. We need people who understand evidence-based medicine, a little bit about research, and you get that through Consumers United for Evidence-Based Healthcare. There's an excellent course that Kay Dickerson has put together and is available. We don't expect you to be experts, and we don't want that. We want common sense. At our institution, the American Academy of Otolaryngology Head and Neck Surgery, we have published and refined our guideline process, which basically consists of developing very actionable, clear statements. Generally in a process of 12 to 18 months, we like to have it published, and we associate evidence profiles where we'll explicitly kind of lay out why this came about. We don't strive to have 100 different recommendations in a guideline, and I think guidelines get confusing if you do that. So perhaps 8, 10, 12, maybe 15 recommendations in a guideline, all very clearly stated, and our process that we follow has been articulated and continues to be refined. Guidelines absolutely are not a review article. Review article is where you just gather a whole bunch of evidence and try and summarize everything. That doesn't help people. Guidelines have to be actionable. So there are different actions that clinicians may take, and the statements in the guideline are going to prescribe a certain action. It may ask the clinician to interpret data, to perform a test, to prescribe a medication, or perhaps just to counsel or advocate. They're diverse, but they're all actions. We don't want statements of fact in guidelines. Facts are nice. For example, pneumatic otoscopy, or using an otoscope to look in an ear and puff some air in, is the most accurate test for picking up fluid in kids' ears. But that doesn't help us act. What we really need is a statement telling the doctor, the clinician, what to do. They should use this. Similarly, we know that well-designed trials show many episodes of sinus infections in adults go away on their own. Nice to know, but the statement in a guideline may say that observation without antibiotics can be used in very selected cases. We know that swimmer's ear has very bad pain. Nice to know, but wouldn't it be nicer to have a statement advising the doctor to explicitly ask about it and then treat it accordingly? Last, antibiotic therapy doesn't help children who have their tonsils out, at least given right before and right after surgery. In most cases, it's of no benefit. There are Cochrane reviews to show that, but the real message is clinicians should not routinely administer it. We always want statements of action in guidelines, not statements of fact. These action statements have a format. They tend to describe when something should occur, who is the person specifically that should perform the action, some level of obligation. The clinician must do such and such. The clinician should do this. The clinician may do this, and of course that level of obligation is going to tie into the level of evidence. What exactly should they do, and to whom? This is what goes into an action statement, so a statement can actually be implementable. I'm going to go through a couple steps now in our process of developing guidelines, and in that process I want to highlight also the role of consumers in adding to the richness of the process. The first step in a guideline begins with defining topic and scope. This is often done through a conference call with the group and perhaps some email exchanges. What we're doing is to really narrow down what are we talking about. Are there age restrictions? Are there restrictions in the type of setting or place that this guideline will be implemented? Are there only certain types of clinicians that we expect to follow this? And what's the scope? We're not talking about an entire disease entity. We're probably going to focus on a few opportunities. The next step, also usually taking place through conference calls, is to flesh out a list of what are the needs, what are the quality improvement opportunities that exist given this topic and scope. And this is independent of evidence, so we don't want to just focus on topics where there's a lot of systematic reviews. We also want to know what are the real needs. These topics begin through a discussion with the group, and we might say, if we could discuss only a few things to improve quality of care, what would they be? And I can assure you the consumers are going to have a different answer than the content expert or than the in-the-trenches physician or maybe the allied health professional. They all have different points of view. What could we do to minimize harm? If there is high-level evidence from systematic reviews, we obviously want to consider that. But the point is, this approach driven by quality allows us to consider all topics, at least as potential action statements in a guideline. We then end up formulating a big list of these topics after they're refined, and here's about 20 topics that were proposed for a in-press guideline at the time of this recording, January 2012, on the management of sudden hearing loss. It was a multidisciplinary guideline, and these topics came up as potential things to have action statements about. I highlight a couple of them here because these are the ones the patients, the consumers, really advocated for, supporting and counseling patients with unresolved hearing loss. Really the role of patient preferences in the whole decision-making process and what might be the role of some complementary alternative therapies. It's interesting to see that these topics were ranked lower than some of the purely medical-related topics in this list. The lower down on the list, the less important the group as a whole considered them. Nonetheless, they were all considered in the guideline because of their importance, and many of them did not have systematic reviews or much evidence. We did do our best to find supporting evidence, but these are important topics. I want to emphasize, again, two ways of doing this. Some guideline panels are really purely evidence-driven. That is the driving force. There are extensive literature searches, evidence tables, and basically if there's not evidence, we exclude it from the discussion. Many times these produce practice parameters, evidence reports, evidence reviews, and they're very helpful and valid products to produce. I would submit that the real approach to really developing a useful guideline is to use the evidence more as supporting cast, meaning that we define the QI opportunities first, the real needs of the consumers, of the public, of the doctors, of all the stakeholders. We then seek out the best evidence to support those. And in cases where there is not great evidence, we fill in the gaps using explicit processes to show how the decision-making occurs, and that involves evidence profiles. These QI opportunities are quite numerous. We've mentioned some of them, and they may range from promoting appropriate care to avoiding inappropriate or useless care, facilitating access, facilitating communication, empowering clinicians and patients. These are all very valid topics to include in a guideline. They've been enumerated here in another publication from the Institute of Medicine. To summarize this section, we've spoken about defining the topic and scope and then formulating this list of topics, QI opportunities, independent of the evidence level. The role of consumers here, again, is to bring that common sense. It's to bring up topics that might be missed by clinicians alone. It's to really advocate, to throw in the importance of considering adverse events, of harms, of advocating for the patient, for educational. And this is a critical point where the consumer input can guide the whole guideline process. Here's an example from our sudden hearing loss guideline, soon to be published, of a statement that came about purely as a result of consumer initiation. And it's a statement that patient education, this is an action statement. So there's an action requested of the clinician saying the clinician should educate patients with a certain type of hearing loss, idiopathic sudden sensory neural hearing loss. It's a mouthful, but that means sort of hearing loss that's very sudden onset with no known cause, about the natural history of the condition, the benefits and risks of medical interventions, and the limitations of evidence. And it's a strong recommendation. This is accompanied by some tables in the guideline that lay out this information in a patient-friendly way to communicate from the clinician. Moving forward down the guideline development process, having this list of topics, we now need to refine the list based on existing guidelines, reviews, trials. We need to look at the evidence and then prioritize these topics into what actually will become the guideline. This is where we find the intersection between the systematic review process and the guideline development process, an intersection that's been highlighted in the Institute of Medicine reports on standards. The systematic review process often occurs independently of guidelines, but can sometimes be driven by the needs of a guideline development group, and I think more and more we're seeing interactions in this area. The guideline development group uses systematic reviews as some of the raw materials to develop some of the strongest statements. Again, we don't need reviews on everything, but we like to have them, and if they're out there, they're very helpful. Sir Ian Chalmers, who's one of the founders of the Cochrane collaboration, 1993 is when that started, highlighted the importance of pausing to reflect, really understanding the limitations, the shortcomings. What does the evidence say? And we really need, if we're going to improve the effectiveness and the safety of healthcare, we need systematic reviews to guide us. So they're critically important in driving this process. Shown here are the revised level of evidence definitions from the Oxford Center. At the top are different types of studies, whether it's treatment, prevalence, prognosis, or assessment of a diagnostic test, and then there's a level. The point I want to emphasize in this new classification is that level 1 is always a systematic review. It's been accepted now that having a robust collection of evidence, particularly if it's homogeneous, is far superior than one or two isolated studies. So systematic reviews are very important to guideline developers. Here's an example of a key action statement that we developed in a guideline on vertigo, on dizziness. And these are just to show you how some of the action statements can fall out. For example, we recommended clinicians should assess patients with this type of vertigo for factors that might interfere or modify their approach. The clinician may offer vestibular rehabilitation. It's a type of physical therapy that can benefit the patients. We're also not afraid to say what shouldn't be done in our guidelines, and in this case, obtaining radiographic imaging or testing such as a CAT scan or x-rays should not be done. It doesn't help, and it just has adverse effects. Similarly, treating with vestibular suppressants, there are certain antihistamine drugs or similar drugs that are widely prescribed to treat vertigo and dizziness that have no benefits but are chock full of side effects. They shouldn't be used. And indeed, I think the role of consumers is often to highlight the importance of avoiding useless medicine. Diagnostic tests, interventions that may not have proven benefit but do have harms. They're out there. We like to talk about them on guideline panels, and certainly a big focus of the U.S. healthcare agenda now is avoiding inappropriate or potentially harmful therapy. This summarizes the action palette, at least an abbreviated version of it, of words that we might use in crafting our guideline statements. A word that we do not use and we really want to avoid is the consider word. You may read guidelines that say the doctor should consider prescribing an antibiotic for this infection. Well, consider is a soft word. It's impossible to measure. It's impossible to see if somebody considered without some sort of a mind-reading apparatus, so we avoid that word. To summarize what was just said on the last 2 points, we do have to refine this list, develop our key action statements. And again, the consumer role here is critical. It provides that balance. It brings the common sense to the process. It focuses on adverse events and harms and really speaks up for patients' rights. So it's important, if you're on a guideline panel as a consumer, not to just be there and understand the process, but to participate, to speak up. And any good guideline development group, the moderator is going to allow everybody to have a say and respect people when they speak and ensure an open flow of discussion. The last step in this development process I want to cover has to do with adding evidence profiles to really refine these action statements and give them meaning and transparency. Evidence profiles are statements that follow the key action statement. So the layout of a guideline would typically be to have a statement recommending an action, then some supporting text to describe why that statement was written, what are the citations, systematic reviews, evidence supporting it. We then list a profile, very explicitly stating the quality of evidence that supported it, any benefits from following that statement, harms that may accrue, the cost. How does it balance out? Is there a preponderance of benefit over harm, or are they sort of equal? Any value judgments that went into developing it, the role explicitly of patient preferences, and any exclusions that might apply. The reason we do this is to really encourage an explicit process, and most importantly, to create organizational memory. Any of you who have served on guideline panels may have had the experience where you develop some statements and then 6 months later you're talking about something else. You go back to the first statement and you're having the same conversations all over again. People forget. So having evidence profiles really spells out in detail why decisions were made. It gives you that organizational memory, and it allows outsiders who are looking at your guideline to really understand why and how you developed these statements. What was the thinking behind it? A person may or may not agree with what a guideline panel comes up with, but at least if you're transparent, they can see how it was developed and express their agreement or disagreement intelligently. Here are some examples of guideline statements. This is a statement about sinusitis, acute sinusitis in adults, and it's a statement that asks the clinician to take an action of distinguishing whether the sinusitis is a bacterial infection that may need antibiotics or a viral infection. It's very explicit in how to do this. It basically says that if it's a very prolonged presentation, 10 or more days, or if there's been a so-called double worsening, the patient is sick, gets a little better, then gets sick again, those would suggest a bacterial infection. This is a strong recommendation. The evidence profile behind it is shown abbreviated here. It shows there are good studies to support this. The benefit, of course, is to make a better diagnosis and more appropriately use antibiotics. There are some harms, but quite minimal. There's clearly a preponderance of benefit over harm here. There are some value judgments that went into this. The guideline development group in this case really felt it was important to avoid inappropriate antibiotics, and that the best way to do that would be to make a clear distinction between viral and bacterial illness. Why is this a strong recommendation? How does that language come into it? Every guideline group needs a way to classify their recommendations. There's always two processes at work. One process is to rate the strength of the evidence. The other process is to translate that into some prescription for action, whether it's a recommendation, a strong recommendation, an option, or maybe no recommendation. And the way that's typically done in most guideline schema is to begin with some ranking of evidence quality on aggregate, and then combine that with an assessment of benefits and harms. And to weigh those two are the two primary ingredients. There are other ingredients such as our confidence in the evidence and our certainty, but these are the two primary ones. The process developed at the American Academy of Pediatrics and that we've used at the American Academy of Otolaryngology Head and Neck Surgery is a fairly straightforward one using this scale. And in the example I just showed you, we had grade B evidence that allowed us, because there was a preponderance of benefit, to either make a strong recommendation or a recommendation. It was felt to be a critically important issue of this diagnostic aspect, so it was made a strong recommendation. The policy strength, strong recommendation, or option carries an implication for the doctor as to how compulsive, so to speak, they should be about following it. It's been shown through some research that generally doctors and clinicians tend to sort out three levels of obligation, and these can be equated to a strong recommendation being a must or a should action, a recommendation being a should, and if something's an option, then the clinician may choose to do it or may not choose to do it. We want consistency. Here's an example from a recent guideline we did on tonsillectomy, one of the most common surgeries in children. And in this case, some recommendations were made about the frequency of infection to justify tonsillectomy, as well as documenting the episodes being a certain severity or having a high fever or a positive culture for strep, and that if those things were met, it was an option. It was a very reasonable thing for the doctor to propose tonsillectomy. Let's take this a little further and look at the evidence profile behind it. In other words, why, if these are such good criteria, is this just an option? Why not make it a recommendation? Here's the statement as it appeared in the guideline. And the evidence profile was pretty good. There are randomized controlled trials based on these criteria to show a benefit in children if you take out the tonsils. That benefit being a very modest reduction in infections and severity. The problem being there's a real potential for harm with an invasive surgery like tonsillectomy. There can be hemorrhage or anesthetic issues, very, very rarely even a death from this type of surgery. And because of this real potential for harm, there's a somewhat uncertain balance going on here between the small benefits and the uncommon but potentially serious harms. The value judgments here are specified. You need to take these into consideration, and there's probably a large role for patient preference given this uncertainty. So the evidence profile here really allows people to see the decision-making process. And when put onto the grid that I showed you before, this would come out as an option. We have good evidence, but the balance between benefits and harms is a little uncertain. So this is an option. There's room for decision-making, particularly shared decision-making. And in these option statements is where that paradigm of shared decision often comes in. And I will say that consumers are generally the most vocal about honoring and preserving this shared decision-making paradigm. Rightly so. Here's a guideline we did about hoarseness, stating that when someone presents with hoarseness, the doctor should not prescribe anti-reflux medicines, so prescription antacids or other medications designed to reduce acid in your stomach for patients with this unless they have clear signs or symptoms of what's called gastroesophageal reflux, that burning in the chest, that really sour taste in the mouth. If that accompanies it, fine. But if it doesn't, to just empirically do it is a bad idea. And this is supported by good evidence, randomized trials showing that unless you've really looked at the throat, at the larynx, to verify signs of reflux or inflammation, just sort of prescribing based on the history is not a good idea. There's no benefit. And we do, of course, have a cost and harm to this type of therapy. The value judgments involved here relate to an acknowledgement that there is some controversy about this. There is a need for further reflux, but at least for now, we have demonstrated adverse events and no benefits in this particular situation. Again, it's different if the doctor has taken the time to examine the larynx and seen inflammation. It makes sense to treat. To summarize this part, the evidence profiles are critical in assigning the transparency of the process. And again, the role of the consumer here is also quite important. It's going to come into that patient involvement section, into the value judgments, into the benefit and harm. So there's many places in the evidence profile where consumer input is very important. At the end of all this, we produce a guideline, and the question becomes, is it truly actionable? Have we achieved what we would have liked to achieve? There's a wonderful tool for assessing this called GLIA, the Guideline Implementability Appraisal tool, which is a standardized tool developed at the Yale Center for Medical Informatics. Rick Schiffman was behind this, that allows people to systematically take the statements the group develops and see, are they actionable, are they clear, are they transparent, can we implement them? And here are some of the things that are considered. Or is it easy to make decisions based on the statement? Can we execute it? Is the process clear? Do we know exactly what is being asked of the person doing the statement? Can we measure an outcome? And these are assessed using a process that's articulated in the GLIA documents. And at the American Academy of Otolaryngology Head and Neck Surgery, we take our 12 or 15 guideline statements after they're developed, and our staff have been trained in this process, and they pick them apart to be sure they are individually actionable and implementable. And often some very interesting results emerge requiring changes in the wording or in the phrasing of a statement. So it's a critical process to do before the guideline is released. I began early in this task by saying, what are the possibilities for consumers? At the most fundamental level, communication, consultation is probably better, but our approach and what we believe at the American Academy of Otolaryngology Head and Neck Surgery, and what I would personally advocate for, is full involvement of consumers on guideline development groups. This is also clearly the intent of the Institute of Medicine with their new guidance for trustworthy guidelines. Our preference is to have at least 2 consumers involved in this process. I stated earlier, what do they contribute? And I think these are critical aspects of the process. And if they're not there, if that passion is not there, if that protection for patients, the respect for harms and adverse events is not there, it really harms the process. Again, it's important for consumers to be true participants. If you are invited to the table and to participate in the guideline development group, you have an obligation to speak up and to voice your opinion. What I haven't covered in this presentation is what happens after the guideline is developed. There is a process of extensive external review, which may involve consumer or patient groups. There then is a process of peer review and review by the board of directors of whatever organizations will be endorsing or releasing the guideline, and eventually it's published in a peer-reviewed journal. Many times guidelines then will become performance measures, where they are used by the American Medical Association, Physician Consortium for Performance Improvement, or other groups to develop measures that can be actually implemented in real care settings to see if critical aspects of the guideline are being followed. To end the presentation, I think the educated consumers can clearly be some of the best members of guideline groups. There's a terrific quote from Alessandro Liberati, who unfortunately passed away in January 2012. He's one of the founders of the Cochrane Group and did run the Italian Cochrane Center. He said that the challenge is now, and by now we're referring to 15 years ago in 1997, the challenge is now for the medical profession to develop alliances with consumers, to move forward toward a wider recognition of the uncertainty and weakness of medicine and the biases in the process of setting research priorities. Alessandro was talking about research. I think this could have been equally applied to guidelines. And I love the words uncertainty and weaknesses and biases. This is part and parcel of the fabric of medicine. And I think the role of the consumer in highlighting these and making sure they're discussed is critical. So with that, I will end this discussion, and again thank Consumers United for Evidence-Based Healthcare for being a terrific source to us and other guideline developers of educated consumers, and for the opportunity to share this presentation with you.